So thank you very much for joining us. And now I will turn it over to Dr. Velasco.
Thank you, Dr. Martin. So I'm Dr. Velasco. Hi, everyone. So today, as Dr. Martin said, I'm going to talk about evaluation for suicide, especially in the child and adolescent population. So I would like to start with the risk factors, which is the main thing that we evaluate when we start seeing a patient. So we can divide the risk factors in different ways. So I'll start with the personality risk factors. So things that that will increase the risk in patients for suicide will be patients presenting with hopelessness, impulsivity, aggression, perfectionism. Then we have the cognitive factors when the patient is very rigid, when there's thought suppression, there is fearlessness or pain sensitivity, and agitation. Then we have the social factors. It can be social transmission, social isolation, or a negative life events. So it could be childhood adversities, traumatic life events, and physical illness. So I will also like to mention, so we can divide also the risk factors at non-modifiable risk factors and modifiable risk factors. So when we have the non-modifiable risk factors, we have the male being a male, being older or in middle age, Native Americans, Caucasians, being on jail, prior suicide attempts, history of family suicide attempts, and then we have the modifiable risk factors, which are the most important because are the ones that we can make some changes and help the patient. So if there is a presence of mental illness, if there is history or current alcohol or substance abuse, as I mentioned, feelings of hopelessness, also if the patient, for example, doesn't have any family support or any support at all, medical illness, chronic pain is very important, or that when the patients do not have access to treatment, to psychiatric treatment. So that's very important to keep in mind because we can, if we treat the patient for pain or for psychiatric illnesses or substance abuse, we can decrease the risk of suicide. Then we have the positive factors. So we have, it could be optimism, resilience, and problem solving. So the protective factors, for example, also if the patient is able to get treatment, psychiatric treatment, treatment for substance abuse or alcohol abuse, if the patient as well have a good support system, not only family, because some patients don't have access to have a good family support, but support in the community. Also, it's important that the patients have access to medical care because if there is any chronic medical illness or pain, that can be as well treated. And also when patients have skills in, as I mentioned, problem solving and coping, that also can be modifiable in the way that if the patient have access to therapy, psychotherapy, they can improve their skills. So next, here we have kind of the biological changes that might be related to suicide. So there is a genetic changes. Then, as I mentioned, it can be trauma, childhood adversities, traumatic life events, or physical illness. Then we have the neuroendocrine changes with changes in the hypothalamic pituitary axis. Also, neurochemical changes, increase in norepinephrine, increase in dopamine, or decrease serotonin. It has been found that in patients that have committed suicide, there is decreased levels of serotonin. So, and also personality factors, as I mentioned, and the cognitive risk factors that ended up in a suicidal behavior. So, what are the warning signs to keep in mind when we have a patient, especially kids or adolescents? So if the patient started talking about dying, any changes in personality or changes in behavior, changes in sleep pattern, changes in eating habit, and fear of losing control. So it's very important to have all in mind as according to the CDC, The suicide is the number 10 cause of death overall in the United States, and it's the second leading cause in populations in ages from 10 to 34, and the fourth leading cause in patients from 35 to 54. So it's very important to do a good evaluation when we see children or adolescents. So when we do a screening to assess the risk for suicide, so it's important to focus on the content and the nature of the suicidal ideation and ask questions like, what are the thoughts? The thoughts are active at the moment when you are evaluating the patients, or they are passive, how often they occur, they increase in intensity or frequency, how long these thoughts last, and if the patient has an urge to follow these thoughts. Then ask about planning, if they already have a plan, if they have they know the time that they will do it, how they will do it, if they think they will work and it will actually kill them. So in that way, you can assess how severe it is. Then access to means to go ahead with the plan. If they have access to firearms or medications, if you are thinking about the patient is mentioning overdosing. So it's important to ask not also about firearms, but also medication. So then if there's factors related to intent, so there's any motivation. So how strong is the intent? If they know when they're going to do it, if they're planning to do it when they're alone with their family around, or if they have actually started doing anything or prepared to do it. Then also it's important to evaluate the emotional behavioral regulation. As I mentioned, if there's hopelessness, helplessness, if the patient uses drugs or alcohol, there's any other psychiatric comorbidity, medical comorbidity, or how impulsive is the patient, or if there's a history of aggression, which also increases the risk of suicide. There's any stressor in the life of the patient, and also very important, there's any support system, not only in family, but friends, or even in the community or at school. So what we use to assess the severity is the Columbia Suicide Severity Rating Scale. This is the one for children. So what do we assess? So first we start with the wish to be dead. So we ask the patient if the patient has been having thoughts about being dead, or if the patient wants to be dead. Then we have the non-specific active suicidal thought. If the patient has thought about doing anything. Then we have the active, and as I mentioned, if there's any methods, if there is intent, if the patient has a specific plan. Then the intent of the ideation, if it's and how frequent it is. If, for example, it's only one, it has been only one time, few times, a lot of times, and if there's anything that stopped the patient about thinking of these thoughts. Then if the patient has had in the past any actual attempt and how they did it, then if there was any interrupted attempt, then if there was an aborted attempt when they started to do something, but then they were stopped for some reason, if they have any preparatory acts of behavior, because will increase the risk of the patient actually go ahead and attempting suicide. And also we assess if there was suicidal behavior during the assessment. So again, we also assess if there was any physical damage or medical damage to the patient ended up in the hospital in previous attempts, if there were, and the lethality of the suicide attempt. And so then something before that I go to management that I wanted to mention. So most of the patients that have committed suicide, they haven't been seeing a mental specialist or any mental health professional the months or years before doing it. So that's something to keep in mind. So because if patients maybe have access to care, and the risk of suicide will decrease. Something that is very important as well is the treatment of psychiatric comorbidities, because 90% of the patients that commit suicide have a comorbidity, a psychiatric comorbidity. It increases the risk of suicide by 20 times. So the main the psychiatric comorbidities that increases the risk the most is eating disorder, followed by major depressive disorder. So eating disorder increases the risk the most, but it's less common than major depressive disorder. So major depressive disorder, followed by bipolar, schizoaffective, substance use, borderline personality disorders, and anxiety disorders increases the risk. Then something that we have to keep in mind as well is that having a chronic medical illness, any debilitating illness like renal dialysis, HIV, or cardiorespiratory illness increases the risk as well. I know that will be less common in the child and adolescent population, but still something that we have to keep in mind. So then after doing evaluation about management, after doing the evaluation, the screening, the next decision is management. So if we're seeing the patient in the outpatient or there, so we need to admit the patient, or we are going to continue the care as an outpatient. So what are the things that increases the risk of things, like it increases the option of hospitalizing the patient. So if the method was very lethal, if the patient still, after attempting, they're still having suicidal ideation, inability to discuss about what happened about the suicide attempt, when the patient has an inability to discuss about a safety plan. For example, if you go home, you think you are going to be able to call back or go to the nearest ER or call 911, when there's no alternative for adequate treatment and monitoring in the outpatient. If there is psychiatric disorders that hasn't been treated, if there agitation, impulsivity, or severe hopelessness, and of course for social support, because if the kids go back home and there's no family members that will monitoring them, so that increases the idea of sending the patient to the hospital. So then we also have medications that can be used to the if the patient goes outpatient and go back home, it's important to assess if the patient has firearms or any medications that to be removed. That's importance of having social support around the patient, and optimizing the psychiatric treatment if the patient has psychiatric illness. And we have medications that have shown to decrease the risk of suicide. For example, lithium that works in patients with, we can add it as an adjunctive treatment in patients with a major depressive disorder and bipolar disorder. We also have clozapine that we use with patients with schizophrenia or schizoaffective disorder, have increased suicidal ideation, and of course, antidepressants. Also, we have therapies that will help improve problem-solving skills, like cognitive behavioral therapy, dialectical behavioral therapy, and problem-solving therapy. So other thing that is important to always discuss with the patient, that if you are going to start a patient in an antidepressant, there's a black box warning. So yeah, someone is asking about the slide. So I'm on this slide. So it's important to discuss with the patient that there's a risk, especially in children or adolescents up to age 24, that when you started on an antidepressant, there can be an increase of suicide ideation. So we have to educate the patient about that. So if they start having suicidal ideation when we start an antidepressant, they know that they have to call or communicate with the psychiatrist. And so then we have the options of the involuntary hospitalization, and as I said, outpatient treatment if there is not an increased risk of committing suicide after discharging the patient, psychotherapy, as I mentioned, and the pharmacotherapy that I mentioned. And also we have sketamine or ketamine when we have patients with severe suicidal ideation. So we also have programs like school-based prevention, community-based prevention, and the resources always to share with it's very important to share with the patient and have a plan with the patient. So I always discuss with my patients even what are you going to do if you start having suicidal ideation? Are you planning to call me? Do you have my number? What if you cannot reach me? What would you do? Who would you call after that? And would you call 911? And I also offer them all the resources that we have in the community. For example, then if they want to call the National Suicide Prevention Lifeline, 8255, and for example here in El Paso, if they want to call EHN or call the clinic, and we always let the patient, if there's an emergency, to go to the nearest ER. And that's it with my presentation.
This would be a great time if anyone had any questions. Let's see, we have our first question. Yeah. Carolyn Carlson asked if you could please discuss involuntary hospitalizations for patients less than 18 years. Now, I can take that question if you want. Okay, so this topic definitely varies from state to state, but we're all supposed to be here in Texas. But just keep that in mind if you do practice in more than one state, which a lot of people do in this area. It's different in a very interesting way in New Mexico. So first I'll talk about Texas. In Texas, what you need is the parent's permission to admit a patient to a hospital if they are under 18. If you have the recommendation and the parent agrees with it, then we can admit the patient. Now, as outpatient providers, it does get a little complicated because you're not the one that's actually admitting them. So this really is a discussion between the admitting physician at the psychiatric hospital or the psychiatric ward and the parents of the patient. As outpatient providers, the most important thing to do is use the trust that you've built up with your patients over time to help them understand what you, as their longtime provider, think is the best option. Because parents don't like to do this, of course. It's frightening for them, especially if it's the first time. But at the same time, there is a procedure if the parents are not able to be talked into, or if they're not in agreement with either the admitting physician or any provider that has seen them in the community. You can do an involuntary hospitalization the same way you would do for an adult. Usually we don't go to that extreme. If the parent really doesn't want the patient, their child, to be admitted, then we try to think of other alternatives such as partial hospitalization. A lot of times, if the parent we really feel like the parent is in denial and they're not understanding the dangerousness of their own child, then we have two options at that point. If we really, really think the parent is not making the right decision and they are putting their child at imminent risk, and it can't be like, well, they might benefit from an admission to a psychiatric unit. It has to be imminent risk of suicide, as in today or tomorrow. They might commit suicide. You can go through an involuntary hospitalization by filling out just one sheet of paperwork and then sending it to the appropriate authority in your area. And you can always call the El Paso Psychiatric Center if you need some advice on how to do this, but also it's done all the time in emergency rooms. Outpatient providers usually are not, but you can always call us too at CPAN and we can get you the paperwork. The other option that a lot of, that I've heard of people using is calling CPS. If the patient if it's not immediately a risk, if you don't think the child is at immediate risk, but you think that it really is not to the child's that is to the child's detriment, that they're not going to go into the hospital, you can call CPS, and CPS will follow up with the parent and the child to make sure that things aren't going downhill quickly. This, of course, is seen sorry, this is a very long answer to a very short question, but it is a really hard one. Of course, the parents see that CPS getting involved. Sometimes they feel threatened, and sometimes they change their mind when they know that CPS, like that the provider feels so strongly that they're going to call CPS on this family. They change their mind and they actually agree to the admission. So you don't ever want to use that as a threat to the family to get them to do what you think they should do. But if you are genuinely concerned about that child's safety, then it is the right thing to do. Let's see. Oh, someone asked, and it's the same as, so the next question is, would you do the same assessment on a child that's 5 years old? And that's definitely completely different, right? Dr. Velasco, it's hard to explain how that would be different. So most of the time, now I'll tell you, there is one assessment that they claim, the writers of it claim that it can be modified for preschool children. But I'll tell you that suicide in a child that is under 10 is extremely rare. We did have a suicide in this community with a 9-year-old boy last year, but it's extremely rare. We probably won't have another one in that age group for years to come. Thank goodness it's extremely rare. And the assessment is different, but the assessment that you can find online and has a training that goes along with it is called the Columbia Suicide Screening. And it's from Columbia University, and they have a grant called the Lighthouse Project. And the Lighthouse Project, the Lighthouse Project is a grant that they have a whole website where you can learn how to do the screening instrument in all different age patients, and in all different settings, like in the medical setting versus the school setting, outpatient setting versus emergency room. And so I would really, anybody who's interested in this, that would be a place to start. For a child that's less than 5'2", it probably, sometimes they talk about death, but they don't have the same understanding that we do as adults, or even that a 7 or 8-year-old child. Usually around 6 or 7, children start to understand the permanence of death. But it's a process. It's a process that begins, maybe somewhere around the age of 4 or 5, when they start to see, a pet die, or even an insect die, or a bird die. They kind of build on that until they really understand that when you're dead, you don't come back. And then what suicide really is, and what killing yourself really is. And of course, a child that's been brought up in a more traumatic environment where a lot of people have died, or someone actually has killed themselves, are going to be a lot more interested in this topic, might make a little quicker progress. But really the progress on understanding death as permanent, that's probably the most important developmental milestone when you are assessing children because a lot of times we'll get kids referred from the schools because they said something like, I just want to die, or I just want to kill myself, or I just want to kill somebody else. A lot of times they're saying it because they're mad. So that's probably the most important thing to differentiate with the younger children is, okay, do they understand what death is? And because if they don't, they're probably meaning something else than they actually want to be gone forever. And then understanding what situation they said it in, and you can ask them, were you mad when you said that? What were you mad about? And usually it's they're mad, or they're in trouble, and they heard someone else say it and they got a big reaction. There's a lot of different reasons, but it is important to know what the situation is, so we don't end up sending a 5-year-old for an inpatient hospitalization. It's extremely rare that we would need to hospitalize a 5-year-old, even if they have said a lot of things about death, because they do have their parents there, and they do let their parents, for the most part, take care of them. the point at which we hospitalize really young children is the point at which their parents are unable to manage their behavior in a way that's safe. And a lot of times it has to do with not just the child's disorder or behavior, but the also the parent's abilities as a parent to handle these difficult behaviors. So it is pretty rare to get a child that young. And in general, 5-year-olds don't understand death. So, but Columbia suicide screening is they have it different versions for different ages. Dr. Ginato, what risk factor should actually alert the parent, and what is the greatest factor a provider need to look for within the short time of the encounter? It's probably, you want to answer that one, Gabriela, or you want me to?
No, it's okay. Yeah, so as I mentioned, the risk factors that the parents should be alert is changes in behavior, as I mentioned, changes in personality and events of aggression, impulsivity, or of course, if the patient have done anything to start any attempt of suicide. And as a provider, well, the same factors reported by the parents, but also, as I said, if you have a patient with with symptoms of depression that haven't been diagnosed and is very depressed and haven't been on treatment, so that's very important as well.
And one of the I would really encourage people to be guided by the PHQ-9 adolescent version for any kid that's 12 and up, because there is, of course, a progression of the suicidal thought. So let's say you think that the child's depressed, then you would want to go to the questions about, have you thought about suicide? And then one thing that's really important to understand, and that parents don't always understand, is that bringing up suicide will not cause someone to commit suicide, or to think. It's not like you're going to cause them to think of it and then all of a sudden they're going to. There's been a lot of research on that study, and it does not increase suicide to be asking about suicide. And actually, there's another kit that is called the ASQ for younger kids. That one is specifically developed for pediatric clinics. And so that might be one you want to use too. And I think that one goes a little bit younger than the PHQ-9. But really what's important is, okay, if they're having the thoughts, have they thought about how they would do it? If they've thought about how they would do it, do they actually want to die? And so those are the sorts of things to focus on once you've identified that there are suicidal thoughts. And then a lot of clinics have a set of screenings that they do when certain things come up. So let's say the kid has lost weight and the mother says the kid's really irritable. Well, then that might be the time to do a PHQ-9. And then if the PHQ-9 says anything about that the child's thinking, the adolescent's thinking about suicide, then do the Columbia Suicide Screener. And the Columbia Suicide Screener is not assessing whether the person's having suicidal thoughts. That's what the PHQ-9 and the ASQ do. The Columbia Suicide Screening assesses that area between, okay, it assumes the person it's to be used when the person already has been identified as having suicidal thoughts, but then where do you go from there? Do you go, how far have they gotten along that pathway? And then also it looks at protective factors, risk factors, impulsivity. Impulsivity is much higher in boys. And so that's probably one of the reasons why boys do complete suicides more often than girls. So that is a very, very important factor. Another very important factor if you're looking at mid-adolescence and on is substance use. The older someone gets, the more highly correlated substance use is with the actual suicide attempt.
There is another question about what screening tool. The screening tool that we use is the Columbia Suicide Risk Assessment.
Yes, the Columbia. It's the CSSR, the Columbia, what is it? Columbia Suicide
Screening. I have it.
Screening Risk Assessment. I don't know. We'll maybe put it in the chat. Can you do that,
Yeah.
Gabriela? Okay. Let's see. And then Dr. Ortiz is asking a question. How do you recommend talking to parents who are concerned about the black box warning on SSRIs? For example, why are we trying to treat the mood disorder that's causing suicidal thoughts with something that can cause suicidal thoughts? Okay, that's a great one. And it's very, I've seen different people do it different ways. So yes, if you say that the FDA has put a black box warning because this one causes suicide, then you are not going to get many people trying an antidepressant. How I explain it is that, so there's been a lot of research that went on since the black box warning. So the original study that, again, this is going to be a long answer to a short question, but you got to, and then of course you got to rearrange what you're going to say to the parents depending on how much the parents want to know. So the original study that the black box warning was based on did not include any patients that actually committed suicide. It did. They did show a higher amount of suicidal behavior and suicidal ideation, but it was not a huge risk. And so then, so they put the black box warning, and then they did a lot of research afterward. And that was a point at which the suicide completion rate in adolescents increased significantly. And so that's usually what I say. There is a black box warning, and I'm not sure why they haven't taken it off, because it looks as if as soon as the black box warning went on, the suicide rate in that population actually went up, not down. So if it were really protecting children to not put them on antidepressants, then you would have seen the opposite, right? And it wasn't the case. And then also the original study didn't have actual suicides in it. And it's hard because this population who's having suicidal thoughts already, they're going to be at higher risk for suicide and for a lot of other psychiatric problems functioning. Okay, someone is asking, what are your thoughts on calling CPS when you suspect that a single parent is mentally ill and the caregiver and the parent is mentally ill but is calling you for help for their children? Mental illness is kind of a separate issue. So for example, you almost never get your children taken away because you have a mental illness. So it's not the mental illness, it's whether you're able to take care of your of your own child. And sometimes they are not. But I've been doing child psychiatry, and I'm sure there's a lot of people from UPS in the audience. We always have them. So if they want to comment on this too, in the chat box, that would be great. Most of the people that end up getting their children taken away have substance use problems, not mental health problems, but sometimes they go along together. There's higher rates of substance use in people who have psychiatric problems, and people who, so it goes both ways. If you have psychiatric problems, you're more likely to use substances. If you have substance use problem first, then you're more likely to have to cause a psychiatric problem. But a lot of that is independent of whether they can take care of a child. So that's what you really want to think about when you're calling CPS, in my opinion. And this is a gray area. But most parents with mental illness, especially one that would be calling you as a provider or a teacher or whatever, it could be that you can get them some kind of help and not have to call CPS. But here's the other part. CPS has a lot of resources that can help parents who are having a hard time. Now, most people look at CPS as okay, I'm in trouble now, but they have a lot of really great services. And somebody who's calling you asking for help is probably going to be a lot more appreciative and a lot more understanding and willing to engage in those services in a positive way because they've already are asking you for help. So those are the things I think about. Oh, and then and the parent has not sought help yet. So if they haven't sought help for themselves, I address that with the parent directly first, especially if it's to the point where I'm thinking that they might not be able to care for their child. And I'll tell you, so many parents, in my experience, will get help from themselves if you frame it as it would be good for their child, it would be helpful for their child. They'll do so many things for their children that they will not do for themselves. Okay, we have some, I'm gonna go switch over the chat real quick because the CPS, people from CPS I think are commenting. Let's see, yes. Here's some of the comments. Dr. DeVargas, CPS has programs such as Home Safe that will support the family. So that's something really important. And then many parents are able to provide care for their children with mental illnesses, especially offering support services and stabilizing illnesses. So most psychiatric illnesses, you can become stable. Even if it's a severe one like schizophrenia, most of the time we can stabilize the patient to the point where they can care for their children. Here's another audience member saying, I usually tell parents, parents who tell me that, oh wait, this is about the other one. And she was talking about a different question, sorry, about the SSRI question. I've seen some patients become more depressed on a particular SSRI and another med, and this can be dose specific. Okay, that brings up, going to that topic again, that brings up a really important point. I always tell patients and parents that you don't have to get worse to get better. We want you to start this medication, and you should be getting better, not worse. If you're getting worse, it's the wrong medication. You need to just stop it. And it's just a starting dose so you can just stop it right away. There's no, it's not like you can taper down off something if it's already the smallest dose. So, because it seems obvious to us as providers, but no, it's not obvious always to parents who don't have any medical training and who have never really thought about it before. They've just heard that you're supposed to taper off. So I said, no, you just go ahead and stop. If this is not good for your child, you're the one that's going to know first, and you need to be the one to just go ahead and stop and then call me. And so I think that probably eliminates a lot of the problems that you can get in terms of side effects from antidepressants or any kind of psychiatric medication. If they're getting more irritable, more outbursts, more depressed, you want to stop it and then call back to the clinic and we'll discuss it again. Here it is, Columbia Suicide Severity Rating Scale. That's going back to the exact name. And I think somebody put that, did we put that in the?
I put the link.
Oh yeah, Lori put that in the chat, the link to it. Great. Okay, here's another question. What have you observed as the adverse outcomes of a young child being hospitalized for mental health issues, such as suicidal outcries? A lot of times, I guess the worst thing that I've seen in terms of hospitalizing kids and it not being a positive thing have to do with the separation from the family. So, the younger the child, the more that we want to keep the children together with their parents and their families, their caregivers, whoever it is that is taking care of them. And so I prefer to really concentrate on trying to help the parents of younger children manage their children's symptoms and behaviors instead of admitting to them. So really, it's when this is just absolutely not possible that we would recommend an admission of a really young child. And most services these days, psychiatric hospitals, psychiatric units, what they will do is they will evaluate the child themselves. So let's say you're an outpatient in an outpatient provider in a pediatric clinic. One of your patients is suicidal to the point where you really feel uncomfortable. I would ask the parent to take the kid somewhere to be assessed. And the places in town that have it, that do that service are El Paso Behavioral Health and Rio Vista. The El Paso Psychiatric Center is no longer seeing children. This is they turned their COVID ward into their children and adolescent ward into a COVID ward. So that's not available right now. But the other two places will evaluate the patient themselves and then make a separate recommendation than the one that you send in. So that's important to know too, because you might want to call that family later in the day to say, okay, did they get admitted, or do I need to help them with some other kind of arrangement? So that's that's something, but I haven't seen any really any terrible adverse outcomes when we admit young children. You do want to involve the family as much as you can, just so they don't feel as homesick. I mean, homesickness is probably one of the bigger ones. And also, you don't want the family or the patient to think of psychiatry as the enemy, because then that will prevent them for many years, perhaps their whole life, getting help that they really do need. Dr. Gennaro is asking, which instrument is more useful, the PHQ-9 or the Youth PSC-17? They're very similar. It really, I don't think there's a big difference in terms of being more useful. It's just which one you like better. But they are very similar, and they're both, they both have been tested over many, many, many years. So they're both considered valid. Here's another one. Conducting the PHQ-9 and knowing that discussing this doesn't contribute to suicidality. Should we encourage parents to have discussions with their children about suicide as a mental health component, such as we do recommend with sex and substance use? Okay, now you're asking me as a psychiatrist. I'm going to say 100% yes. I'm sure other people have different opinions, but it is clear that the only thing that causes increases in suicide in terms of talking to each other are if you have a suicide in a population, in an adolescent population, you are more likely to have other kids in that community will commit suicide. That is a common finding. It doesn't happen all the time. It's still a rare finding, but we do see that at times. Whereas talking about it in a preventive way, hopefully is preventive. Now, the sad part is that we haven't figured out how to decrease the suicide rate. It goes up and it goes down. Right now, unfortunately, we don't know about this year. Everyone has a lot of questions about COVID. Is COVID going to make more children commit suicide? And it seems like so far there's nothing in the literature, although the last time I checked was a month ago or so, but there's nothing published in the literature that shows that we're having any increased suicide rate amongst anyone, adolescents or adults. So that's the good news. But COVID has certainly caused much, much distress. So yes, I would absolutely advocate for parents to talk about suicide with their children. And it's something that the kids are talking about. So I think it is good. It's kind of like sex. Like, you don't want them to learn about sex from only the other kids at school. You want them to learn from somebody who actually knows what they're talking about and can support them. Let's see. What advice do you have when you disagree with a doctor's treatment? For example, several psychotropic medications being prescribed to children 2 years old, 3 years old, and 5 years old. I would recommend calling up that doctor and discussing why it is they have them on those particular medications, talking with the parent about how they feel about it. But one of the things I always do before I kind of jump in there and try to get kids off of a whole bunch of meds is I really pay attention to finding out the history in terms of how was that kid doing before they were on these medications and how are they doing now? Because one thing I see a lot is a child has a really severe disorder. And so somebody starts a medication, they don't get better. They add a medication, they don't get better. So they add another medication, don't get better. Then they add a fourth medication and so on, without saying, okay, if that first medication didn't help the kid, well, then you should stop that first medication before you start something else. So that's what we try to teach our residents to do, especially with children. Start one thing at a time, one medication at a time, and really assess every time you make a change, whether the kid's getting better. If you've done 3 increases and the patient hasn't gotten better, but they got better with that first dose, well, maybe you should just go back to the first dose, because usually decreasing the dose will decrease the amount of side effects. Not always, but usually. But I would, I don't know, when doctors call me, I always call them back. When providers call me, when the therapists of my own patients call me, I always call them back. You won't get that with everyone, but it's a way to start. ADHD, let's see, Amanda has a question about ADHD, unspecified disruptive behavior disorder, autism spectrum, borderline functioning. Okay, she's talking, that's part of the previous question. Those are the types of diagnoses that she's saying that they're recommending medication in under 5-year-old children. Now, usually child psychiatrists don't start medications before 5 years old. The rare instances I do, and this is just me, the rare instances that I do, it's because it's almost always because it's a single parent. The child cannot tolerate being in daycare, or the daycare cannot tolerate the child. And they keep getting, so the usual thing is that the child is very disruptive. And a lot of times the kid's not even that unhappy, but a lot of times they just can't be around too many kids at a time. And a lot of times it is those exactly those diagnoses that Amanda just listed out. And so I try to put them in behavioral treatments or recommend behavioral treatments, but then if the parent is in danger of losing their job because they have no one to care for their child, sometimes I will start a medication. I almost always will start with a stimulant, a short-acting stimulant, and not something heavy like an antipsychotic. But the antipsychotics are approved to very young, in very young children. So, and there's definitely evidence that stimulants work in very young children. But that's kind of what I reserve those medications for. And there aren't really that many people who prescribe antidepressants in really young children because there's just no evidence that they work very well. Somebody's asked the next question: would psychotropic medications being prescribed to children 2 years old, 3 years old, and 3 to 5 year old increase the risk of suicide? Not that we know of. It's so extremely rare that this age group would commit suicide in the first place. It's almost impossible to study. The vast majority of suicides are in age 12, 13 and up. So it's really hard, and it's hard to know. I'll have to go and look for studies about this topic, looking at it from another perspective in terms of, okay, if kids are treated with medication when they're really young, does it worsen their outcome when they're older? I really am not sure about that. But in general, I and most of my colleagues here at Texas Tech tend to not use that much medication at all before the age of 5. What if a youth is saying that they feel they need to be seen more often, but a therapist is too busy? I really do recommend changing therapists, and I'm sure there'll be therapists that'll be mad at me for that, but I really do recommend that. It is a dangerous situation to take on too many patients. And usually where you're going to see this is in agencies where the therapist doesn't have control over how many patients they take. Sometimes they get stretched a little thin, and I think it can be a dangerous situation. So, and even in my own clinic, I don't take more patients than I feel like I can. I need space. Like if there's an emergency that, someone needs to be seen before their 3-month follow-up, I need to be able to fit them in. So I think it's really important to only take as many patients as you can care for. And there's always going to be other therapists, especially in the El Paso area, not so much in the rural Texas. But hopefully, I don't know. Hopefully that's not too much of a problem, but I would consider choosing a therapist who could see them at least once a week if that's what they need. And sometimes a lot of times insurance companies will approve twice a week, but people rarely follow up on that. But it is, a lot of times they will approve it. Let's see, here's another comment about using ADHD medications in an extremely hyperactive child if they're endangering themselves. And that's absolutely true. Some of these kids are so hyperactive and so impulsive that if they don't have a little Ritalin on board, they're going to run out in the street and get run over. That type of situation. I think that's what Dr. Carlson's referring to, but please correct me if I'm wrong, but I definitely have had that situation too. Do you have a good resource on finding local suicide rates for a specific area in Texas? Oh, the best places are to make a request into your local medical examiner's office. The CDC will look, I think it goes down to the state level. I don't think it goes down to the county level. So if you're looking for your own area, then the medical examiner's office is always the best place. And it is public record. Now, of course, and this is horrible to have to talk about, but there have been so many people that have died in the last year that every medical examiner's office in the entire world is completely overburdened. And so you're probably not going to be able to look at anything for 2020 yet. But the 2019 is already published. So you can go back and look at 2019 and you would be amazed at how much information you can get from your medical examiner's office. And they publish a report. It usually comes out midway through the next year on every single death in whatever region they cover. So for here, it's the El Paso County Medical Society. Medical examiner's office, sorry. Oh, and I realized I talked about New Mexico in terms of involuntary hospitalizations, and I never went back and I mentioned them, and I never circled back and talked about that, and as opposed to how Texas handles it. So in New Mexico, you are treated as an adult in terms of consenting to a psychiatric hospitalization at age 14, which I don't know of any other state. I haven't looked at the laws in any other state, but of the states that I've worked in, that is very, very much younger. In Texas, you can sign yourself in as a 17-year-old, but you can't even sign yourself out as a 17-year-old. You have to wait till you're 18. You have to have your parents' permission to be signed out of the hospital. But in New Mexico, if a 14-year-old gets admitted and decides they don't want to be there, then they go through the same process that an adult would, which would be you'd be appointed an attorney, and your attorney would represent you. And here in Texas, it's probate court. Some places have a special mental health court, but basically a mental health court. They would represent you and to say to the judge that you want to get out. You want to get out of the hospital, and you have to prove to the judge that you should be able to. I had a patient that did this once, and she did not. Her first request was denied, and the judge asked for the patient to be hospitalized for 2 further weeks, and then they would reassess. And so at that point, the patient had already been discharged, because usually children have very short hospitalizations compared to adults with, say, schizophrenia or bipolar disorder. You guys are asking some really terrific questions. Oh my goodness. Let's see. Oh, okay. Amanda is asking, she's an LCSW. She's asking about CEUs. We are working with, we're having a symposium in April, on April 8th, and we are joining up with the Child Guidance Center for that one. So we are looking into both continuing nursing education, continuing education units for LPCs and LCSW. So we need to get on the ball, because we had no idea that so many of you all would be interested in this. But now that we know, every week there are so many different professions logging on. So I'm so happy. I'm so happy and so we do need to get on the ball and get you guys your professional credit too, because it's great to get education knowledge, but it's also great if you meet all your requirements for your licensing. And we're working too on making sure we've added topics that are now mandatory for the different types of licenses. Let's see, Sandy's asking a question about neuroenergy feedback and addressing children's mental health. Some parents swear by it, and they say that their child has really benefited greatly. And other parents that have done that with their parent, you go to a clinic, you do neurofeedback. It's usually done by an occupational therapist. It's I'm not exactly sure how it works, but it's very non-invasive. You have little things sticking on your head. And to the kid, what the kids always tell me is, oh yeah, they stuck some things on my head and then I watched a video. So I know it's more complex than that, but that's how the child experiences it. So if you have a child whose parents don't want to do medication, and who don't want any other intervention, it might be something to consider. It can't, in my opinion, it's not going to hurt them. And it could be helpful. And I'll tell you that they want you to go 2 to 4 times a week. So it's very time intensive. So it's really a hard one for working parents. Okay. Well, thank you so much, everyone, for coming. And then let's see, could we need to put in our phone number. So you all can always, I'll put it in the chat. Our phone number is, oh wait, there it is.